Webinar's live. Yay.
Yeah, brilliant. Hello, my name is Michelle Ross and welcome to cliniQ's webinar. This is our first webinar in our series of TransHealthMatters. We've had 6 in-person conferences and this is a continuation of that, and there'll be several more webinars going forward. I'm with some amazing people today who I'll introduce briefly. They'll introduce themselves, and then when we come back to start with the presentations from each person. As you can see, this webinar is about sex, PrEP and HIV, trans and gender diverse people. The hashtag for today is THMCQ 2020, and the Twitter is @cliniQ. I'll just go to, I've got a few slides that I want to share with you before I introduce the panelist to set the scene. All right. In the UK, there's PrEP on the NHS, and it's for all who need it. There's a campaign at the moment on PrEP for all, and that's for all genders, for people of all genders who need PrEP. And there's not an equal access to PrEP in many situations, especially for certain people, Black and men and women, who might access PrEP in a different way to the clinical services where it's usually provided in the clinic. And there's many other people that might not know about PrEP, and it's really important that while PrEP is on the NHS, it needs to be as wide as possible for people who need PrEP. So it's a national programme, must also understand and seek to address the structural inequalities that drive inequality in PrEP access. These include working to address community-level socioeconomic and cultural factors. And you can see there, PrEP for All, there's a flyer there. And you can sign this at tht.org.uk/PrEP for All. And you can sign it as an organisation or as an individual. Right, I'll just go to my next slide. I'm just going to go through a few slides before we go to the panelist who's got a lot to say on many of the issues we'll be talking about today. So often, I've heard that, trans, queer, non-binary people are hard to reach. Well, they're not hard to reach when you know where to look. Actually, these days, trans people are everywhere, so it seems. But, and I see a key population often in terms of HIV, and I sometimes question that because of the lack of investment in trans people, the lack of focus on clinical research by trans people, for trans people. A lot of the clinical research is done by cisgender people with not often designed with trans people. And that's really important to change. There's a lot of people that can do all that, who are trans. And there's a real exclusion at that level still in design and research by and for trans people. In the UK, there's no data on STIs for trans people. Now that we have data from 2015 on HIV, which I'll talk about in a few seconds, but we still don't have any data on STIs, and that really needs to change. And if I know key population can often mean around HIV, well, the key population is also including around STIs. It's the whole thing: sexual health, HIV, the full thing. And the lack of trans men, trans masculine people in HIV clinical trials and global response is unethical. there really needs to be a complete change around that. And I know Max will be talking much more around those issues. And just think that I skipped over, Black trans women have an increased risk of acquiring HIV. And for money, social, societal, and institutional issues that increase Black trans women's at risk of acquiring HIV. Now, sex, we all know that we're in a COVID situation of a pandemic. And while certain tests or maybe HIV diagnosis, new diagnosis might be being reduced while PrEP, while COVID is here. But sex happens, it still happens, it's not stopped. And as this trans woman who lives in Brazil, where there's many issues there, I still go out, I still have sex, because if I don't, I'll die of hunger. And although her livelihood depends on sex, for many people, sex is really important, and that's not stopped. So it's really important throughout COVID that PrEP is available and easily accessed. I'll just briefly go through these. This is with the data in England about trans people accessing HIV care. And in 2000, up to 2017, it was 123 trans people were recorded as accessing HIV care in England. And as you can see, before this, we had no data like this. And up to from 2015 to 17, this was the data that's collected. Now we know there's an underestimate, there's hidden figures in this. And since then, more diagnosis of people living with HIV, trans people living with HIV, is clearly happened. But in this research, in this data set, there was 88% female, trans female. Male, it was 8%, and gender diverse, it was 4%. And the residency where people lived was mainly in big cities, but 56% live in London. And with, I think, easier access to informed services around HIV and trans people. The age group, as you can see here, there was age 50 plus was 31%, age 35 to 49 was 42%, and age 15 to 34 was 27%. And I say that there is actually a paper coming out soon that gives much more details on this. And I didn't know I could put you all down there. Now I can see my slides. And so ethnicity, BAME was 38%, and 62% were white people, white trans people, accessing HIV care. Now, in some countries, in other findings, the BAME or Black trans people, there's far higher incidences of living with HIV. But in this country, and some people might say that 123 from 2017 is not a high population of trans people living with HIV in the UK. And this is not about chasing numbers; it's about accessing data and what the data pulls out. But also, if there's a low incidence of HIV in the UK, that's a comparable study. You can see why is it low in the UK and why is it high in some other countries, and what are the conditions that create that. Keep trying to go to, yeah, great. So this is just brief. This is only a tiny part of the findings from the data. There's a cascade of HIV care in the UK, 2017. So as you can see, blue indicates trans, and you'll see in a moment compared to cis people. So another 100% of people were diagnosed with HIV, 98% on ART, HIV medication, and 97% had viral suppression. And this is compared to cis people. As you can see, the diagnosed is the same, 100%, and on ART, the same, 98% for both. The difference here is only a slight difference in viral suppressed, is that for trans people, 97% were viral suppressed. So that is a good viral suppression, and 95% for cis people. You see, we had none of this data before, none of this findings for 30 years in the UK. So a late diagnosis, 40% of trans people compared to 43% of cis people. Complexity, clinical complexity. Now I find the next findings quite interesting as to why there are clinical complexities, and in this 23% compared to 14%. So 23% of trans people had clinical complexities compared to about living with HIV to 14% of cis people. Underactive psychiatric care, so 16% of trans people compared to 4% of cis people. So, you know, so this is also about some trans people will be accessing gender care and might be going under a psychiatric care. Or it could be about the complexities of being trans and living with HIV. I don't have that full details here, but more details will be in the paper that's about to come out. So when you take out the clinical complexities on the middle part of this, excluding psychiatric care, you can see there's 13% of trans people and similar levels for cis people. Health and quality of life. Let's bring this up. 41% felt depressed or anxious. 23% for cis people. For trans people, reported health or bad health, 40%, and 26% for cis people. And problems with self-care, 36% of trans people felt that this was very present for them, whereas 13% of cis people was, so there was a difference there. So I've come to the end of my slides, and I was hoping that'd be briefer than what it was, because I'm really keen and eager to hear the speakers. So this is cliniQ, and did I mention cliniQ were an award winner for LGBT Diversity Award as an organisation in 2019, and this is some of our team at the clinic on a Tuesday with the lovely Sarah and Victoria. Okay, great, that's me done. Okay. I'll just take my slides out. Oh wait, how do I stop share?
Like that.
Great, like that. Great. So we're back to the panelists. I wonder if you could all introduce yourself. Gus, if you'd like to say who you are and what you do briefly.
Yeah, I'm Gus Cairns. I'm not a trans person. I'm a cis, gay, and a bit bisexual man. Been involved in HIV forever, but as a job since 1998, which was when I became undetectable. I've been editor of Positive Nation, the UK's first HIV magazine. I was interested in prevention from an unusually early time for somebody who started off as a treatment activist. I first heard about PrEP in 2002 at a talk by Bill Gates. And I ended up being community co-chair of the PROUD study, which was one of the 2 European studies that really sort of clinched that PrEP was extremely effective. As well as being one of the two staff editors at NAM, I organise a thing called PrEP in Europe, which is basically a fairly informal umbrella organisation, 7 or 8 European NGOs. We've had 2 very successful in-person summits, Amsterdam and Warsaw, about PrEP in Europe, but COVID threw us all into a spin, like everybody else. And we are at the moment doing a series of webinars, and the next one will be on PrEP in trans people, and it will happen on Friday, November the 13th. At the moment, we don't have a time, and that's because I'm still seeking presenters, a couple of research presenters who tend to come from different parts of the world. And that's what I've got to say about myself.
Great, thank you, Gus. And I was just reading something then, but thank you, that's brilliant. And I think that's really important about the PrEP in Europe for trans people. And you'll be saying something about that at the end of your slides, won't you? Yep. Okay, great. Erika, I wonder if you'd like to say a few words.
Yeah, thank you, Michelle, and thank you everybody for joining us. I'm Erika Castellanos. I'm Director of Programs at GATE, Global Action for Trans Equality. And as I'm a transgender woman living with HIV, diagnosed in 1995, so my HIV activism has come from a long time now, particularly started in the Latin American region, where at that time there was a lot of struggles around access to care and treatment. So I have seen a huge development and difference. I've moved to the Netherlands recently, a few years ago. And it's, you know, it's in the HIV treatment world, coming from a Latin American country, there's a huge abyss, a huge gap in the difference of treatment and care provided in countries such as the Netherlands. But particularly, you know, I think I'm very happy to have the discussions today about PrEP. Particularly coming from a movement at that beginning, the movement of people living with HIV in the regions where I live were very much against PrEP rollout. So how have we come from that point to where we are now as persons living with HIV advocating for PrEP use? I think this will be an interesting discussion. Thank you, Michelle.
You're very welcome. We're just trying to, so thank you, Erika, that's brilliant. And I love all the work that you do. And I'm so pleased that you're here joining us today. I'm just finding out that we're not on gallery view for the audience, and I want us to make sure that we are, so people can see us all here at one time. So please bear with us while we try to sort that out. Okay, great. And until we do that, Sarah's working behind the scenes here, trying to arrange that to happen. I can see you all on gallery view, but apparently some of the audience can't. Great. So Max, would you like to?
Yeah, sure. My name is Max Appenroth. I am based in Berlin. I'm a trans activist, and I am also working for GATE, Global Action for Trans Equality. And with GATE, I am coordinating the working group around Trans Men HIV, which is a trans-masculine-led group. Trans-masculine means that the people from our group are female assigned at birth, but do not identify as female. They identify somewhere on the male or masculine spectrum or non-binary spectrum. And we are an international group of currently 23 participants from 18 countries across all continents, which I'm very proud of, that we actually managed to get a group, like a really diverse group, not only geographically, but also like from the people who are part of the group together. And I am also doing my PhD in public health at the moment with a specific focus on sexual health of trans people.
Great, thank you. And that work is so vital. And thanks for all that you bring to that. I've just been told that we're now all on gallery view for everybody who's attending. Great, okay. Eli, would you be able to say a few words about yourself and let people know who you are?
Hello everyone, I'm Eli. I'm a queer trans man living with HIV and more frequently working around advocating for young people living with HIV within the UK, but often talking also about young trans people living with HIV and the barriers that exist that prevent trans people from being represented and that prevent them from accessing care in the UK. And yeah, apart from that, I also do a lot around the global response to HIV and AIDS, and I think really that's me, yeah.
Absolutely. Thank you. And then, I see you and the campaigns that and the words you express in social media. And, my heart gladdens that your presence is there and the words that you say are so important. And thank you for that. Okay. Victoria, do you want to say a few words? And Sarah's going to say a few words about herself. I know she's quiet at the moment, but Victoria, if you could say a few words.
My name is Victoria Cordova. I'm another trans Latina from Argentina, living in London for the past 12 years, and I'm a newly member of cliniQ, and I'm looking forward to participate in these discussions about trans and access to PrEP.
Fantastic. Thank you. I'm so glad you're here. We're going to have interesting discussions, I know, with you here. Sarah, do you want to make yourself visible and say hello to everyone?
Hi, everyone. Yeah, I'm Sarah, work for cliniQ. I've been a member of cliniQ for about 3 years now. You saw me in the slide on Michelle's presentation. I'm one of the people that works at the physical clinic on Tuesday afternoons at the Caldecott Centre at King's College Hospital. And I'm doing the technical behind the scenes bits today.
Incredibly well,
thank you. As many other things that I do.
Absolutely. So many things you do. Thank you for that. So now we're going to start with Gus, and we're going to have some Q&As as well about the presentation. Gus, would you like to start your presentation?
No, now you can hear me.
Yeah.
And I'm going to start my presentation. You should be able to
yeah.
See the whole thing. Okay.
Yeah.
All right. Okay. Right. I'm going to sort of rush through this because there's a lot of data, and I'm a real data nerd, and but basically it starts from where Michelle left off, which is that when you start researching trans people, you come across huge lack of research, and this is partially because of, I think, conceptual ideas about who trans people are and how they should be described. It was very interesting doing this research because I realized several things. Firstly, I'm glad Michelle showed the slides from the UK because that's just about the only bit of research I could find that had actually taken place in Europe that was actually published in a journal. Virtually all the research I found about trans people in the trawl I did comes from the US, or Southeast Asia, or a little bit from Latin America. Very little in Europe. Hopefully that will change. And I also found, I think, probably the first mention of trans people in the context of HIV prevention. Anyway, which was 2005. So it shows that things have changed a lot since then. So the questions I'll be trying to answer is, how many trans people are there? Yes, we go back to that. We go back that fundamentally, because that was a question that came up in Michelle's presentation. What are their HIV prevention needs? How many have HIV? How many know about PrEP? How many are using it? Does it work for them? And what do they think of it? The last question I'm only going to touch, because I think that's probably more of a matter for the rest of the panelists. So I'm not personally, I'm not a trans person myself. But anyway, and to give you the answers in advance, spoiler alert, we don't really know how many trans people there are. It depends how you ask. We don't know what their HIV prevention needs are because we need to know more about who they have sex with and how. We don't know how many have HIV because it depends which group of trans people you measure it in. Probably not nearly enough know about PrEP, and certainly not nearly enough are using it. And yes, it does work if they take it like it does for everybody else. And from what I gather, they like it if it's provided in a way that suits them. So that gives you the answers. Here's the reasons for the answers. Now, when I was doing my digging, I found the first mention I found of trans people within the context of HIV prevention was a piece on AIDS Map in 2005, which was reporting on the study. And it was amazing. I won't say who the writer was because it's completely unfair. But just to show you some of the quotes, it was about men who have sex with men in Thailand who often do so with transgendered men known as katui. Well, these days we would describe those people as transgender women who do not perceive themselves to be engaging in sex between men, right? Absolutely. They couldn't find any katui participants, although and then they say this astonishing statement: the majority of men who have sex with men in their cohort reported sex with katui, in other words, transgender women. In fact, of the men who didn't exclusively have sex with cisgender women, 85% exclusively had sex with transgender women and not with other men. So whatever this was, it was not a study of MSM. And the authors also remarked that when they did a Google search on the word katui, they found 25,000 mentions of bars, clubs, dating services, chat rooms, you know, but not a single mention in the scientific paper. So this may be the very first time anybody thought to write about transgender women in the context of HIV prevention. And just to underline it, to take us right up to almost the present, trans women do not have the same partners as gay men, and so those partners should not be described as MSM. And this is a nice little diagram from a study in Lima, Peru, that shows that. And it shows that the transgender women in this study were the green circles, and their partners were mainly cisgender men who are in blue. 97% of 203 partners of transgender women were cisgender men. And when they asked about those 203 men who their last three other partners had been, 100% said at least one of them was a trans woman, 55% said at least one was a cis woman, and 7% said at least one was a man. Okay, so partially we've been asking the wrong people the wrong questions, and we've been assuming that trans women are a kind of MSM, and that sort of conceptual thing is what's held back the research, I think. MSM was invented as a term because gay and bisexual men felt, I mean, this is caricaturing it a bit, felt that saying they were at risk of HIV because they were gay was stigmatizing, because a lot of gay men are not at risk because of what they do. And also, of course, it was deniable because bi men could say, well, I'm not gay, so I'm not at risk. So the sort of mantra, the research mantra came that what you did, your behavior, rather than who you said you were, your identity was more important as an HIV risk factor. But a fascinating 2012 study, which is a big, big database because everyone does national service in Thailand, every young man. And so it was virtually every young man of a certain age in the entire country, found that what people said about who they were actually correlated more strongly than what they said they'd done, if you see what I mean. This is about men, cisgender men, but this obviously applies to trans people. And this is important for trans people because you get drastically different answers in terms of how many there are in terms of the question you ask. And this is a really interesting study. One of the authors is Sari Reisner, who's a fantastic trans researcher based in Boston. And I'm getting funny menu things coming up, that's better. And they looked through 27 studies of trans people. And if trans people were measured by who was on the record, as it were, who had come forward for gender affirmative therapy or for surgery or both, 6.8% out of 100,000 people in the general population, so that's, you know, the whole, everybody's on medical records, was transgender. And that means less than 1 in 10,000 people is transgender. But 6 of the 27 studies actually bothered to ask people about their own identity. Did they think of themselves as trans or non-binary? I mean, the studies asked in different ways. And 335 out of 100,000 identified as trans or non-binary. If you excluded the Asian study, so that's 1 in 300 people. If you included it, it was 1 in 115. By itself, this was in Taiwan, sorry, 1 in 45, which is like the sort of upper limit of the estimates in the population of the proportion of people who are gay. And later on, a US-only study in which they literally phoned around people at random and asked them about their sexual orientation. That's something people could lie about, found that 1 in 500 people answered they were trans. So that gives us a much larger estimate for the number of trans people. And of course, you won't guess about HIV risk unless you get the number of trans people, right? Having said that, if you only count the trans people who turn up to the doctor, you may overestimate their HIV prevalence, their HIV risk. We used to think that trans women in particular were much more at risk of HIV even than gay and bisexual men. And certainly the biggest and most respected study back then by Stefan Baral in 2013 found an estimated HIV prevalence of 19% in trans women worldwide, 22% in the US. That's about 50% higher than in cis gay and bi men. But 5 years later, another study, only done in the US, found a rather lower prevalence, 14%, and for the first time, a reported prevalence of 3.2% in transgender men, which incidentally was about twice as much as what the transgender men themselves thought. But, big but and very sobering statistic, 44% of Black transgender women had HIV, and this is probably relating to people being poor, having no health insurance, and having to engage in survival sex, as Michelle has already mentioned, from quoting the woman from Brazil. Okay, on the right, this is the racial makeup of people in that study, okay? And you'll see that certainly, particularly in transgender women, Black and African American, and particularly Hispanic and Latina are overrepresented. On the left, there's a little bit about trans men, because I said they may underestimate their HIV risk. The trans women had a pretty good idea of whether they had HIV or not. Certainly, it used to be the case that trans men had under-tested for HIV compared with cisgender men who, cisgender gay and bisexual men, I should say. But that caught up in the previous year to the study. So that is a good sign that trans men may realize that they are people who are at some degree of HIV risk and need to test. Does PrEP work for trans people? That's what you want to know. The answer is we don't know, really. We haven't got absolutely clinching scientific evidence because not enough trans people have been included in studies. And to really have a sort of, really good, proper, scientifically established measure of efficacy, you have to have a large study. Okay, so, but looking back to one of the first, in fact, the first study of PrEP in gay and bisexual men that produced a significant result, the IPREC study, which actually finished in 2011, they found, by changing their definition of who trans was, 339 trans women in that study. And overall, PrEP was not effective for them. Okay? But, as has been found in many of the older PrEP studies, and not just the trans women, but cis women too, their adherence was not good. And this is partially because it was a placebo-controlled study. So I think a lot of participants signed on, but didn't really see the point. Anyway, it was poorer. 18% of trans women took enough PrEP to ensure that they were protected from HIV, which is generally reckoned to be 4 pills a week, versus 36% of the cisgender men. And also, 88% of them were having condomless anal sex, receptive anal sex, instead of, so they were more at risk of HIV too. But of the minority who took more than 4 pills a week, there were no infections, versus 4.9% of infections in gay and bisexual men. So that's tentative evidence right from the beginning, really, of PrEP studies that trans women were protected by PrEP. But really, I mean, if you look for a scientific study, you don't have an absolute proof of efficacy since then. There are a couple of things that might. The one that's coming up is HPTN083, which is the very excitable study of injectable PrEP, which reported a couple of months ago. And 550 of its 4,600 participants were trans women, the highest proportion in any scientific prevention study done so far, so good. And injectable PrEP stopped 70% more infections than oral, and the adherence was high on both sides in this study. I think the one I haven't mentioned is that about 96% of people on the injectable arm turned up for their appointments at the right time. We haven't seen results split yet between the trans women and the cis gay and bisexual men, but when we do, we should be able to relate drug levels to incidence in the trans group. In other words, we should be able, there's enough people there for us to say, oh yes, unless their drug levels fell below a certain level, then PrEP was working. The other thing, and I thought about this after I did this slide, was of course we have the impact study in the UK. And there's something like 400 trans people, mainly women, in that study. So we do have a database. And I can't remember if Impact is doing a sub-study of drug levels, but if it is, we might be able to find something from that. Okay. But PrEP uptake in trans women has historically been low. And one of the first studies done in the US, only 1.7% of supposedly gay and bisexual men were actually transgender women. In Brazil has been a bit of a pioneer because it's just sort of more within the culture there, that 24 out of 409, so about 5% of MSM were transgender women. 2/3 of them did start PrEP, and in another one, there was high awareness of PrEP amongst transgender women in Brazil, but only 6% had taken it. Couple of ones from America, and we documents an increase in people, in transgender women accessing PrEP, but still not a huge amount. Very slow, very slowly gathering uptake. About 17% of a group of Black and Latina transgender women, negative ones, who were interviewed in LA. Main reason quoted not to is fear of hormonal interactions. And of course, this is something that you've already mentioned as being very interested in. Okay, so, but I wanted to take a little diversion into how possibly to do it better in terms of trans women, specifically in this case. Which is a wonderful presentation from Vietnam at the World AIDS Conference, virtual conference this year. And Vietnam has considerably increased the number of trans women it has on PrEP from 3 in 2017 to 409 last time, when the study took its data. And they've done it by instituting a unique system of one-stop shops for health, staffed by and run by the communities they serve, which include gay and bisexual men, include injecting drug users, include female sexual workers, but also include trans women, supported by government funding. And they actually established their clinics. They invited the Tangerine Clinic, which I will say more about later on, which is the trans women's clinic in Bangkok, to give info on sessions on hormone interactions, etc. And they've been a terrific success story. I'll divert a little bit, I love that photo, into PrEP uptake in trans men, because as Max says, they lag behind in terms of awareness and of being mentioned. But we have now seen a couple of studies in the US. One from New York of nearly 2,000 transgender men, mostly young, with, as you see, a huge variety of ways of defining their sexual orientation, which I think is interesting and important. 25% at risk of HIV, according to CDC criteria, which is basically a sort of combination of whether you've had condomless sex, whether you've had an STI recently, etc. And 11%, boiling it down to the number of people, of the 205 who'd had an HIV test had taken PrEP. Most of them were still on it. And then one again from Boston. This was of transgender men who'd had sex with cisgender men. So sort of you might call them gay identified trans men. And of those, 22% were on PrEP. So we're seeing the start of reasonable uptake. Okay, back to the PrEP and hormones. It was the biggest gender-affirming therapy, was the biggest reservation trans people had about PrEP, both men and women. So there was a study at the Bangkok Tangerine Clinic, there they are there, of HIV-negative transgender women on PrEP. All were on the same regimen, estradiol plus the androgen blocker, cytoprosterone, and there was a 13% drop in tenofovir, the main PrEP drug, levels when they took it when they were on gender-affirming therapy. That's probably not clinically significant. There's some wiggle room, and there was no change in hormones. That's great. Okay, but they did one, and this got a bit of news, got a bit of traction because it was a bit worrying, in HIV positive transgender women on antiretroviral therapy. So there was similar drop in tenofovir. There was a slight drop in the third drug they took, efavirenz, but there was also a 36% drop in hormone levels, though no rise in testosterone. Okay. So that was a bit worrying, but it's the only study we've ever seen in the literature where hormone levels appeared to drop when people started antiretroviral drugs, and it wasn't in negative trans women on PrEP. Okay. There was another study that came out in 2019 showing significant drops in the PrEP drugs in transgender women who were already taking gender affirmative therapy. And so for 25% lower compared with cis women in transgender women, and 44% lower in rectal tissue levels. And at the time, this was thought to be possibly significant. It might mean, and this is really, I think, where the thing about trans people generally shouldn't try on-demand PrEP. This might mean that four pills a week might not work, but seven pills a week would, which is a comment made by Craig Hendricks, who's a fantastic researcher, who was one of the authors of the study. Since then, however, we've had more reassuring news by Bob Grant, who was the guy who invented the IPREC study in the first place, wonderful guy. And they did a quite rigorous study of 24 transgender women and 24 transgender men who were already on gender-affirming therapy regimens, and they were observed to take PrEP daily for 4 weeks by video link, so we knew they were definitely on PrEP, compared with similar cis men and women who weren't on gender-affirming therapy. No difference in the tenofovir PrEP levels between the men, trans or cis, so not an issue there. Interestingly and unexpectedly, the highest levels of PrEP were in the cisgender women, which is not what we expected. We don't know why. It's possible because it was measured in blood cells, not in vaginal or rectal tissues. Transgender women had the lowest levels, but not so much lower that it would make a difference. So generally, the news is good, but these are all small studies. So I would say PrEP almost certainly produces no significant change in gender-affirming hormone levels. So if you take PrEP, it won't alter your hormones, okay? So that's the biggest fear that trans people are expressing. There is evidence from some studies that some feminizing hormones, but not masculinizing ones, may lead to small drops in tenofovir blood levels, but probably not enough to affect efficacy. However, until we get stronger data from larger efficacy studies, I wouldn't recommend on-demand PrEP in anyone except cisgender, gay and bisexual men, okay? So, because we just don't know about the other holes, basically, to put it bluntly, okay? So that's about that. And really, I'm gonna finish by a few quotes from what transgender women think about PrEP. And really, I mean, this is very recent that people have actually thought to ask trans people who are taking PrEP why they're doing it. There's very few studies, very few qualitative studies of what they really think of it. And just a few quotes, talking about peer influence, wanting to, you know, the encouragement and support of friends, and particularly other women in the trans community, was really important. And also, if there was lack of peer information, then people are not confident to go on it. They don't necessarily trust what doctors say. It doesn't mean they don't listen to medical advice. It's just that they actually want the affirmation of their community. A reminder from the bottom quote that a lot of trans women in particular still live very hard lives. Sexual assault is not an uncommon experience, and that this particular woman, she decided to take PrEP as basically a safety measure in case she was ever sexually assaulted again. A couple more things. First takes us right back to the beginning about you won't work with trans people properly if you lump them in with men who have sex with men. And she was outraged. It's like, are you saying that I'm like I'm a guy? This is ridiculous. But equally, I like the last quote because it's from a trans woman who said, nobody ever really asked me if my dick still works or if I could talk with it unless I brought something up about it. So that also tells us about don't stereotype what people do sexually from the kind of person they are. And that's just something to keep in mind. Okay, so this is a reminder, we're having this PrEP in Europe webinar on PrEP and trans people on Friday the 13th of November. Max will tell you more about that because we're doing a pre-meeting for the trans community as well. The slide comes from the previous PrEP in Europe webinar, so don't take those as being the speakers. I'm still arranging them. I'm trying to get one of these fabulous researchers I've quoted, and don't miss it. The time will depend on time zones and who we eventually get to talk. Thanks very much.
Well, thank you, Gus, for that incredible presentation. My head's swimming a little bit, and I'm used to a lot of figures in my head. But that was fantastic, and I love the way you present things so thoroughly. Thank you. I'm aware of the time though, but I'm just wondering, and there's other people too, does anybody want to make an immediate response to some of the things that Gus has said? Anybody on the panel? If not, then okay. But I will say something. It'll be interesting because we at cliniQ we've worked very hard to include trans people in taking PrEP, in access to PrEP as well, and in an informed way, very much an informed way, whether they've come to see us or the information that we put out there for trans people, either online or physically, paper stuff. And it will be interesting to see a study, if that's possible going forward, of the 400 trans people on PrEP from the impact trial and see what those issues are. Yeah. Okay. So Max, or Erika, yeah.
Thank you, Michelle. Thank you, Michelle. And thank you very much, Gus. I really, really enjoyed your presentation and a lot of food for thought there, a lot of information to process.
Yeah.
So I just want to start with the comment I made when I introduced myself, not that I want to make emphasis on how old I am, but, being diagnosed in the 90s and coming from a region in the world where there was little availability of ARVs, of life-saving medication. When PrEP was introduced in the region, there was this huge discussion about, should we give PrEP to people who are not HIV positive versus we have millions still of people who are not on treatment? Because basically, PrEP is an ARV. So there was a lot of discussion about that in the community of people living with HIV, myself included, because it had a lot of ethical dilemmas there to consider. But one of the things that I do celebrate is how far we have come in the HIV response, how far the community involvement has led to new research, to new advances, to clinical studies, to new medication. And I think while still we have a huge gap on the treatment side, particularly in middle and lower income countries, we're giving great strides towards achieving universal access to care and treatment. So if I ask myself, why should trans people be interested or have access to PrEP? I think first the thing is to say is that, yes, definitely, trans people should have access to any prevention tool that is available. The key thing here to remember is that there are many choices, and one should have a choice, an informed choice, because not one size fits all. So if there is PrEP available in combination with other prevention strategies, I think it's something that we need to take advantage of. and there are many gaps still in the research. You know, Gus highlighted many of these gaps. We cannot say many things first with certainty, with 100% certainty, but we can see some evidence based on those small amount of research that has been made with transgender people, because I totally agree there's lack of inclusion of trans people in research, in all types of research. And you know, one of the things, there's always the question, and I agree with Gus, everywhere when you start talking about transgender people or advocating in something for transgender people, there's always the question, how many of you are there? If it's at a country level, a regional level, or a global level, there will always come that question. And countries try to address that by doing population size estimates, which I hate, particularly in settings where people are criminalized. Because they put people at risk. So we need to find better ways. But I like to go with the highest estimates that people out there throw out. At, you know, they make estimates. Some people mention 25 million people in the world are transgender. I think it's much more than that, but that's my bias. But you know, I think last year I enjoyed a presentation by Dr. Asa Radix in IAS 2019 in the plenary session. I really enjoyed it because it puts, you know, the same way a lot of information Gus also shared, but it talk about those barriers that trans people have for PrEP continuum. And I think that's where we have to have some emphasis to document, to talk about it, and to find ways to address it. The issues, the ongoing issues, that it's not only on HIV, it's not only on PrEP, but that trans people face historically, the issues of stigma and discrimination. It's so profound, and the isolation, and you know, that trans people have to go through. That definitely affects our interaction and accessibility. But you know, it is added with the systematic exclusion from society, from states, around data packages, around opportunities, about around access to social benefits, but in regards to enjoy our human rights in all. So you know, we still see, and we saw examples of transgender people, and we have many examples of transgender women being included in the cohort of MSM. It still happens today. It's something that we really ask that it stops, continuously have to be advocating for that. And I hopefully one day it will be achieved. There are many recommendations about the inclusion of people who are considered to be at high risk, also high risk groups. WHO recommends the rollout of PrEP among such groups. I think there is, what has been happening is the systematic exclusion from an institutional point of view of transgender people, regardless if they're at high risk or not, but also the exclusion from even existence. In some countries, we have some governments that completely say, we don't have that problem in my country. And that is really harsh, and it just puts trans people in a very, very bad situation. So I wanted to talk a little bit, but thank you, Gus. You have already touched about those drug-drug interaction, and the findings that we have seen around estrogen and PrEP, particularly in oral PrEP. And I think, you know, there are two issues that really hit me when you show that data: the issues around adherence and the issues about what estrogen and tenofovir, for example, interaction might mean, because there's not a definite answer. So I think when it comes to adherence, there are so many external factors that might negatively affect adherence in transgender people. And those factors are not only clinical and biomedical factors, but also more of them are social factors. that affect adherence. Also the fear, the lack of knowledge, the lack of targeted advertisement and promotion for transgender people. You know, you're being introduced into something that in many of our minds was created and piloted first for gay men. And so it's like many of my peers have told me they want to impose this without properly analyzing how it will work for me. And this is something that happens common in HIV strategies and programming implementation. Something is piloted, it works really good in a group, and then we think it's excellent, let's roll it out in everybody. And that kind of practices might be more harmful than good. But also we need to start thinking, and we need to have more data about the possibility that as trans women, we may need higher levels of adherence to oral PrEP. What does that implication mean to our lifestyles, to issues around liver function, etc.? There's so many questions. So I think, you know, what this arises is that there's so much more need of data. And we definitely, we need to call for more data, more inclusion. But there are some systemic problems that persist that I think we can start addressing to start opening the doors for transgender people. That historic mistrust between healthcare provider and client. How do we eradicate that barrier when one goes and sees their clinician? When you can look at your clinician and feel that you have complete confidence that they're helping you make the best decisions for your health, where you are the individual that is in control of the final decision and not the doctor. How do we eradicate stigma? How do we properly address the concerns that we have about hormone interactions or any other drug-drug interaction? And how do we address the absence or the very little availability of trans-specific promotion on regards to PrEP? And, you know, as community, we need to start solving these issues. So you know, some people say, oh, we need trans-friendly healthcare providers. Like, I really don't like to use the words because I don't need the doctor to be my friend. I need him to be competent. So I need somebody that is educated enough who knows how he or she will treat me. What is the care I need as an individual? We need to have safe spaces where PrEP is provided. We need to have targeted promotion that I can feel it. When I see that promotion, I say, that's for me. That's something I identify with. And we need to have definitely more data, more research, more studies on drug-drug interaction. There's a lot to say about the exclusion of transgender masculine people on PrEP, but I'll let Max do that for all of you.
Oh, fantastic. Thank you, Erika. Brilliant. Well said. Seriously, you know, absolutely. And thank you for bringing so much of your passion and your informed self to this sessions. I feel immensely moved by what you said. And I think you're right, data. And for me, what's important is the research, the nuances of the research needs to be informed with and by trans people. There's plenty of trans people who are academics, who are professionals in the sector that we all work in that can do this. And opportunities are not often provided for people to do that because, you know, as long as it's nuanced and you know, in-depth research, informed research by cis people, it still needs to be with trans people. Thank you. And I know, Max, you might want to respond.
Yes, I'm gonna respond with some more information. So hang on, I'm gonna share my screen with you.
Also, Max, just to know, there is a question in the chat that I think you might want to address.
Yeah, there's a question on Q&A.
Yeah, we have a look at it. Open question, surely does. Must be aware of the barrier, how it goes across.
Is it the one from Ford?
Yeah, yeah.
Yeah, I think it might be in answered questions or something like that now, because I said, oh, I'm interested in answering that. And unexpectedly, instead of me allowing me to type something, it said, oh, you want to answer it live, do
There's
you?
another one from
Okay. Yeah, there's one from Jamie.
yeah, that is about like categorizing, but I can address that certainly. I mean, like the way of, I mean, we talked about it, how trans women have been lumped up with cisgender gay men, which is like, just from an identity perspective, the wrong approach is like that we as transmasculine people who identify, some of us identify as MSM, are categorically excluded with the excuse that we don't have the right set of genitalia, like all these assumptions about how our bodies are, how our bodies look like, and so on. That is certainly a problem, and I think, or I mean, like, I'm going to tell you a little bit about the work that I'm doing and what we're doing with the working group, because this is exactly what we address. So I will start my presentation from the beginning. Can everyone see my presentation?
Yeah.
Mm-hmm.
So as I said earlier, I'm the project coordinator of the Trans Men HIV working group, which is basically the first transmasculine-led group or initiative in the global HIV response, at least to my knowledge. In terms of working internationally, I'm very sure that we are the first and only group at the moment. And I will tell you a little bit more about this group. As I said earlier, we're currently 23 activists, researchers, public health experts from 18 different countries across all continents. And we do identify as transmasculine or non-binary, and we are all female assigned at birth. And what we do with this working group is that we actually focus on generating knowledge about the HIV-related needs and vulnerabilities of our community, because at the moment there is not much out there. Like research is scarce. There's not many, like most research that exists is behavioral research, but like in terms of biomedical research, there's nothing. Like trans men have been so far excluded from PrEP trials, and like the few trials that have enrolled a few trans men, they just did not have like sufficient sample size to actually make any claims about the efficacy of PrEP in my community. And some of the specific risks of trans MSM specifically is something that we've seen in some of the studies that are out there, is that there is a lack of safer sex negotiation skills. That, for example, I was just part of publishing a paper together with Ford Hickson and our colleagues on the transmasculine or like gender diverse participants in the EMIS study from 2017. And also that study showed that trans men were the ones most likely to say the sex I have, or like they said no to the question, the sex I have is always as safe as I want. So trans men go into a risk when engaging with cis MSM, because often it comes also with the fact that trans people, or like that there's a validation aspect connected to safer sex aspects. That means, for example, that people say, oh, I'm gonna have gay sex with you, but only if, for example, we don't use a condom. So that the validation of my gay identity might be connected to limiting or reducing my actual safer sex needs. There's also, at the moment, there's only, to my knowledge, only one HIV prevention, like official HIV prevention campaign that solely focuses on transmasculine people. That's a prevention campaign from Germany. But other than that, if we are mentioned, then it's only, like, often only on a side note. And that often also leads to the fact that because of not knowing about sexual health needs, or not getting the education that we need, we're also very often less likely to undergo preventive testing. And on a physical level, there's also another specific risk, is that, for example, the use of testosterone in female assigned at birth trans individuals may actually lead to genital or vaginal atrophy that might cause small fissures, and these may be an entry port for bacterial or viral STIs. And also because of using testosterone, the genital or vaginal tissue changes, it becomes thinner, and the combination of both, of like the vaginal atrophy and the changed tissue, is just a really elevated risk for STIs. And also what happens in our bodies is that we often display different types of symptoms or frequencies of symptoms than compared to male assigned at birth people. And specifically now going to PrEP, I told you that there's a tissue change in the vaginal or frontal tissue, and that also in comparison to the fact that PrEP, the shield of PrEP, is built up differently in vaginal tissue compared to anal tissue. And the only thing that we can look at is like, the only studies so far included either trans women, or we can be compared to cisgender women. But the problem is with the changes in our tissue when we use testosterone and if we don't undergo bottom surgery, that actually is at the moment still unclear how that affects the intake of PrEP or the efficacy of PrEP. And also in terms of the how we're limited to the access of PrEP is a lot around stereotypical assumption of how we have PrEP, how we have sex. And this is like one study that coming from the US that actually showed that from the 1,808 participants, almost a quarter fulfilled the CDC criteria for PrEP eligibility. Out of those, 82% saw a healthcare provider in the past year prior to the study. Only, like out of those, again, only 65% actually had been tested for HIV. And again, out of those, 34% had been given information about PrEP. And in the end, was almost 11% out of those who were eligible for PrEP ending up taking PrEP. So you can see how the cascade is going down and where we are limited, like, because like even being given information about PrEP is something very, very crucial. And I just had a really, like, I would always say, like, heartbreaking conversation with one of the people from our working group, a positive trans guy. And he said, like, I wish someone like in the healthcare system would have given me like information about PrEP before I came positive. Because like we are just not given this information because healthcare providers think it is not necessary, but it is. And the problem, and like another problem for barriers to access PrEP is one, what I already said, the exclusion from trials, but also like the absence of knowledge about what are our needs, what are our vulnerabilities. And then again, also like potential costs for testing and medication in many countries, like basically trans people are more likely to live in low income quotas or even in poverty. And that might be a limiting factor. And then on top of that, if you think about that, we actually, like we already have problems accessing general healthcare, like to find a doctor who just treats us for like general medical needs is already, it's really hard. And then thinking that you would need to talk to these people that are hard to find or even might discriminate you, to talk with them about your sexual life, that is almost impossible. And then if that like this inaccessibility of the sexual health system or sexual healthcare system, if that comes along with like mandatory testing every 3 months, if you are being prescribed with PrEP, that is almost an impossible task. And we talked about Gus talked about the intake scheme of PrEP, and it's at the moment based on the lack of research, event-based. He said it already. Event-based intake of PrEP is not recommended, and this is a scheme from the checkpoint in Switzerland. So this is why it's also in German, and they still recommend like 7 days prior to potential risk contact, and then again 7 days after, like to do the date, like to continue taking it also during the period, the potential risky period, but not like only start 2 days where it's sometimes recommended and take it 2 days after. No, 7 days before and after and in between on a daily basis is at the moment the safest option. So one thing that I also would like to address is like the way how we are being treated in cis-gay spaces. And those are a couple of examples of conversations from Grindr and Scruff. From me, like some of them are mine and some are from a friend. And you can just see, you know, like one is saying like, whoever texted fuck before knows that autocorrect changes to duck. So that's happening. But this was a conversation that I had with someone that I asked, like, do you fuck with or without a condom? And then he's like, usually with, but it's a different situation if you catch my drift. And I'm like, I don't catch your drift. What do you mean? And he's like, I suppose I need to be frank. I don't feel a need for condom with you necessarily, but with gay men I do. So you can see that there is not only not validating me as a gay person, but also like this like internalized, I would say, like stigma, internalized homophobia against like that there is a risk with gay men for having to use condoms. But then also like on the other side, like really outblunt aggression against us for not being allowed on these apps, or or being asked if I could just have a glimpse at your sex organs because I'm curious. That happens a lot. It's just like the way we're treated. And the worst part for me is also that this comes from from a queer community, from gay men who know how terrible it is to be discriminated against. And this, for my feeling, makes it even worse. And also talking about like an invisible epidemic of sexual violence, what my community experiences is that like around half of trans men and 3 in 5 non-binary people assigned female at birth are survivors of sexual violence. And this is just something that in the discussion around PrEP and the provision of PrEP really needs to be taken into consideration. So what I usually like try to tell people is that what can we do now is like just to really get away like from the stereotypical assumptions, and to also use an appropriate language, for example, for our genitals. Not everyone, especially like in healthcare settings, not every trans guy or trans masculine person is comfortable with being referred to their genitals as vagina. Or like to ask also for sexual practices, how they call sexual practices, or what sexual practices they actually engage in. And that can only be found out through sensitive communication. And of course, inclusion in research, data collection, and so on is a crucial point to start from. And also, if you are, for example, a healthcare provider, and if testing is necessary for the services, or even for providing and prescribing PrEP, before someone walks out of your clinic not getting tested because you think you need to do the testing with them, like for example taking a swab, give them a sample kit to do it themselves. If they are not comfortable having it done in front of you in your presence, they can also just do it in the bathroom. Like a semi-professional or half professional swabbing is better than none. Oh, sorry, something jumped here. No, sorry. Doop, doop, doop. And what has happened today, which I'm very happy about, is also like that the language of like to refer to cis men. Like, who do you mean? Like if you make a study about MSM and you just include cisgender men, then also please write that you're doing a study about cisgender men, because it is not all men that you're including if you exclude transmasculine people. And of course, generally, like, there needs to, like from my side, I would say there needs to be a revolution in the system, but to say it in a better or nicer way, deconstruction of sexism, misogyny, and patriarchy among cis, gay, and bisexual men. This is something very, very important. So I'm trying to not to use too much time. I would like to jump to the last slide. Like, if you are interested in like, we talked about this meeting from the PrEP in Europe initiative. There will be one meeting on the 13th of November, accessible to anyone like who would like to hear more about PrEP in trans communities. But there will be also, I don't know if today, if there are trans people present, we will have a trans community only meeting prior to the 13th of November. We will have it on the 4th of November in order to discuss and to actually establish some sort of like a list of our needs and claims that we would like to see in future HIV research and PrEP research and so on. And if you are interested in, if you're a trans person, if you're interested in participating in that meeting, please send me an email and I will send you a bit more information about that. If you in general would like to hear more about the work that we are doing, have a look at our website. There's a specific section about this, about our project, about the working group, and also please just follow us on any type of social media to get more information about the work that we do at GATE and also be informed about specific events. And I would like to acknowledge my colleague Keenan Russell, who is also part of the working group, who has been helping with this presentation. And yeah, thanks so much.
Well, thank you so much, Max. That was incredibly informative, but also so needed at this time as well. And I really can't thank you enough for all the content and your delivery on that. I am aware of the time, and I know we've been answering on the Q&A, but I want to also make sure that Eli has his presence here and his voice here, and so I would definitely like to give the words to you for this as we come to the end in the next 10, 12 minutes. So, yes.
Cool. I will be moderately fast. So really, I just want to talk about like my experiences living with HIV and being trans in the UK, and how often it feels like I don't have a voice in like medical settings and just in life in general. So I'll start with saying everyone's experiences are different, and I just want to talk about mine. So really, I'm going to start with what happened early on in my transition. Is I was sat in my GP's office talking about going private, because waiting lists for gender care in the UK that's so long. I've been on a waiting list for nearly 4 years, so it's a huge issue. So yeah, I was thinking about going private, and I was sat in my GP's office talking to my GP, and she was like, "Oh, like, have you thought about the risks?" And I was like, "What risks?" And she was like, "Well, you know, if medication interacts, you need to pick one or the other, and I would rather you pick your HIV than your transition." So I was now stuck in this position of thinking, wow, I need to pick whether I want to stay alive with my HIV or stay alive by being who I am. And it was really hard to like explain to her that both of these things are life-saving to me, and if I did have a choice, I would choose transitioning over my HIV. And I told her this, and she was very shocked, but regardless, she agreed that it would she would do shared care, which is something that private healthcare in the UK, gender care sort of does with your GP, and it's a way of getting hormones faster than the 4-year waiting list. And that was just sort of one of the barriers I started noticing quite young, on top of waiting times and other things. And then growing up, I just started to notice more and more barriers and subtle transphobic sort of, I don't know how to describe it, but small things that were happening to me, such as like I would go in for appointments at HIV clinics and see on the forms and on systems that I had been written down as female, despite telling them over and over and over again that I was male. And I always wondered if, because I was written down as female on those systems, whether my transition was actually being seen in data across the UK, and whether I counted, and I felt very invalidated at that point. So in the end, changed clinic, and now I attend a clinic that's aimed at young people living with HIV. And we had a rocky start. At the start, they were like, "Oh, you're trans, this is new." And after a while, we sort of learned a lot together, and now they're really, really good, to the point where they communicate with my trans clinic, and then it's all nice, everything's good. But I want to talk about other barriers in the UK that affect other people, and a lot of them sort of with data and with misunderstandings in how medical professionals perceive trans people. Because I know that, like, trying to explain to my doctors about my hormones, and then my doctors not understanding what interacts with hormones, and then me trying to explain that, oh, testosterone doesn't really interact with any of my HIV medications. And then also having sort of mental health services on top of that, wondering, oh, but do these drugs interact with your HIV drugs? And do your HIV drugs interact with your testosterone? And it all sort of coincides in a very messy misunderstanding. And in the end, I feel like I have become my own pharmacist, my own doctor, my own scientist, my own sort of therapist as well. And this is a burden I feel a lot of trans people living in the UK, especially living with HIV, they're experiencing that they have to become their own doctor, which is a very hard burden to put on someone's shoulders. And then not only do you have to take on all of this and educate yourself, you then find yourself educating the medical professionals around you who should already be educated, and they should already know how to treat, but also embrace trans people within their services. It's not just a matter of acknowledging that trans people are there, it's about embracing us and understanding that we're not just a one-off. There's so many of us, and we do need to really be seen, and we really do need to be understood. And there are things that, you know, so I frequently find myself educating. It was just yesterday, I was on the phone to a mental health professional, and she was talking about how hard it must be being trans during lockdown way back in March, and how isolating it must have been to have all my support taken away from me. But then she also said, oh, you must have been isolating because of your HIV. To which I was like, no, I don't need to isolate because of my HIV. I actually had to isolate because of my asthma, which shocked her. So then I spent 20 minutes explaining why HIV is now not always something that is a huge issue. And a lot of people living with HIV, well, most people living with HIV are living happy, healthy lives. And it just shocked me how little she knew about HIV, considering I often hear other mental health professionals talking about how many people living with HIV they're seeing, and how many trans people they're seeing. And then I hear them talk about this with pride. And then I look at the way I'm being treated, and I'm like, wow, you really don't know. And that's an issue. And I would really hate for other trans people or people living with HIV, and especially trans people living with HIV, to sort of get into these situations where they are becoming the educator, where that burden falls on their shoulders. And then even beyond like mental health professionals, it's just health professionals in general, and accessing things like PrEP or PEP. And I've seen so many trans people be denied PrEP and PEP because of the way trans people sort of just expected to not be having sex, or expected to, once we talk about sex, we're suddenly no longer seen as trans, we're seen as cis. And that worries me, because I've got friends who are trans who urgently need to be accessing PrEP, but they're so scared to go into a sexual health clinic that they're going to be misgendered and they're going to be treated like a second-class human being, and be denied PrEP or be denied PEP, and so they just don't go. Nobody gets tested out of fear of being misgendered, and I find that so worrying. And it worries me that trans people are being left out in healthcare, and aren't seeking healthcare. And I think with data, it would be really good to have more data on trans people living with HIV, because I know I'm constantly looking for data on trans people living with HIV. I'm constantly looking for information for trans people and PrEP. And I tweeted just yesterday, does anybody have any information, infographics for trans people and PrEP? And there was nothing that was easy to read or easily accessible that I could just find without having to have a really big search on the internet. Which means that when it comes down to explaining to other trans people and the wider trans communities, especially younger trans communities, I find myself saying, oh, trans people can take PrEP without giving them any further information because I can't find anything that's easy for them to understand. And really, these are just a small amount of the barriers that exist, and like there's just a lot of barriers, and I wish I could explain them all in a very short amount of time, but I can't. So I'm gonna now talk about what it is we really need to do to make changes. And we really need to start working with trans people to come up with solutions. We really need to start including trans people. We need to have spaces at tables where trans people can sit and express their views, but not just be the token trans person. There needs to be more than one trans person. There needs to be trans people that represent different groups of trans people, because we are not all just one group. There are multiple different communities of trans people out there. There's non-binary communities, there's communities of trans women, there's communities of trans men. There are communities within these communities. And as Michelle said earlier, we are not hard to reach. Like, we're assumed that trans people are so hard to reach, but we are not. We are everywhere. We are in every aspect of life. And the only reason we say trans people are hard to reach is due to transphobia. It's due to the fact that if we put ourselves out there for you, then we may face discrimination that a lot of us don't want to face. And it's up to a lot of you as cis allies to come out and say, we're here for you, we want to embrace you, and we want you involved in what we do, not just because we need to make up numbers and be more inclusive and for equality reasons, but because we actually want your opinion, and your opinion means a lot to us. And I just think, as trans people, it isn't our job to shout to be included. It is the job of people to come to us and say that we are wanted, and we want you to embrace us in everything that you do, medically, socially, and everything, because we're important and we have so much to say, and a lot of us know a lot of things about a lot of different things, which probably doesn't make much sense, but trans people are needed. And I'm gonna end on that, I think. But please embrace trans people, because we're an amazing group.
Thank you for your words. I feel so moved by what you said, and all your words, every one of them have said the truth. And I so value what you said. I don't know if anybody else wants to come in from the panelist and say something, because you and the experience you have, I wish you hadn't had to have them, is the reason we do, or I do what we do.
And thanks for sharing your experience and everything. I mean, it resonates with me so much, especially like entering into a healthcare system where I, as a person who is not medically trained, am the professional in the room, and this is just something I have to put up with anywhere. And like being asked not only questions about, oh, how should I treat you, but also like, inappropriate questions like that are crossing boundaries at every level. And then really the thought of, with these people I should talk about how I have sex, it's like doesn't sit right. And it's just like, this is a risk in itself that the healthcare system is like forcing on us by not by not training medical professionals to be actually the professionals. And then hearing things like, but men serve every minority, and I'm like, who are you to tell me like that I don't deserve the healthcare that I need? Like, we are people, like I deserve, no matter if there's 2 trans people in the world or if it's like 25 million, like we deserve the same healthcare that anyone else needs or anyone else deserves, and the exact same access to healthcare like everyone else. And that is just something that I think is is the first step in order to discuss actually PrEP and accessibility of PrEP, is like really questioning our healthcare system in a way, like how it serves us generally, and how it fails us, on a daily basis. Like for me, living in Germany, everyone's like, oh, you're safe with COVID. I'm like, yeah, great, I'm safe with COVID, but I'm fucked in any other, sorry for my words, but like I'm fucked in every other way. You know, that's like, that's just a sad reality of our community. And then of course, if there's like multiple marginalizations coming together, being a Black trans person, being a, like, I don't know, you know, like a trans person with mental health problems or with a disability, like, you know, or living with HIV. Yeah, I mean, it's just, yeah, sad. But we'll survive. We have survived all the time, but, and, yeah.
I'm just aware of the time, and thank you, Max. And I don't know if we're still broadcasting, but we are still recording. So, so I'm still. This is a learning process for me when the webinar actually finishes broadcasting, but we are still recording.
So I asked if the recording is actually going to be made accessible after.
I hope that's everyone's permission. Yes.
Okay.
Yes. Okay. So I know that, and it's gone past the time, but Victoria, I don't know if you wanted to say something.
Yes, I want to thank everyone for all the things you bring to the table, but especially Ellie, I feel so moved for what you just said. You know, I came to the UK 12 years ago as an immigrant from Latin America. I've been with the doctors through the same situations as you, so I know. So I think that we need to educate the health, you know, the doctors and the nurses and everyone, because they don't know how to treat us, you know, in a respectful way. So even, you know, I've been through many situations. I can, you know, empathize with you because I've been in, you know, I have the same thing. And I believe that we need to get together and be stronger, especially through these COVID times, because a lot of people are going to be, you know, isolated. And especially, you know, I'm thinking about transgender women sex workers, you know, they're going to be excluded, you know. So, and some of them, most of them are immigrants, and probably they have no visa, no papers. So I'm wondering, how will they access to all of the services, you know? So I think that we need to make outreach engagement and to tackle these communities. Because I had a friend, I recently made a friend through the lockdown, and she's Mexican, she has no papers, and she asked me for help. And so I didn't know where to send her because she has no access to the NHS. So I think that it's very important this, you know, to engage with your, you know, with your community, with trans men, with trans women. You have a sister here for all the things you need. So I'm really glad that I joined cliniQ, and I look forward to bring, you know, all I can from me and my knowledge and my experience for my community. Thank you very much, guys.
Thank you, Victoria, and I'm so glad you're a part of cliniQ. You bring so much to what we do. Okay, so so I still don't know if we're broadcasting, hey,
No,
you know, but we are. Okay, well, we're recording.
So
Okay.
I have to go too. I'm afraid I have to go back to the EAC standard of care.
Okay.
Which is happening at the same time as this. Anyway, it's great. I also typed a question to Anne Sullivan, who I know is there at the moment, saying,
okay.
Are you going to study your trans cohort in impact? So I expected to get back.
Okay. You typed it on here. Okay, anyway, you said that'd be interesting. I can't wait to see Anne's response.
No, she wasn't this. I emailed her.
Oh, there. Okay.
Yeah, actually.
Okay.
Okay, it's been great to meet you all. You're all a complete inspiration. On a personal level, I should say I do have a member of my family in the younger generation who is trans, and watching them deal with it has been a real lesson for me. So I do have a very personal commitment to trans people, and I think you're all very inspirational. Okay.
Thank you, Gus. And
And
You know what? You know how much I love you, well, and admire you, and thank you for
Okay.
being such a supporter and being involved
All right.
in the way you are. Thank you.
Bye.
Bye.
Okay.
Wow. So what's coming to mind is like an hour and a half is not long enough really for a webinar. Right?
Should be 2 hours maybe.
Yeah, easily. And our conferences are a full day usually.
True.
And just on this issues alone is massive, really.
Indeed.
Yeah. So do we want to stay or do you want to bring this to an end for now? Okay.
I mean, maybe I don't know if there's any more questions.
No, I think Gus and Sarah, can you see any questions that's not been answered? No.
There are no other questions from what I see.
Okay, no external questions from what I can see. And so any final words before we end this session for today? It won't be the last from me, from either from what Max is doing or PrEP in Europe, and definitely not from cliniQ.
I think maybe that is important, that I don't know if like who is listening, if it's like trans people or if it's cis people, and like we are dependent on our cis allies, like people in positions that can use their positions to emphasize our voices, not to speak over us or like to run over us, but like to emphasize the voice that we have. And whatever platform you have, like wherever you work, whatever you do, even if it's like on social media or whatever, use your whatever you have, your like, and help us to get this message or the messages that you heard from us today, get them out, and really to amplify our voices and to stand with us and to help get this like moving into a direction where we can eventually one day, like don't have to have these discussions that are so emotional, but like maybe in a way talking about like more about like success stories.
Yeah. Absolutely. And I think for me, absolutely, Matt, I think it's important, sometimes it feels like there's a constant fight for that place, right? And I've been delivering services for 32 years, not always for trans people, and I'm a psychotherapist. And when I say that, about that fight for a place, it's not just me I'm talking about, it's the communities, the trans people, and what you just said about allies and friends supporting voices and giving up some places at the table for that space to be made. And
giving up spaces at the table. It's also like, discussions that I had with trans women, like being afraid, like, what do you want? Like, why do you take away my space? I'm like, no, it shouldn't be a competition. We all need to take one table. Let's just put another chair at the table. No one needs to leave the table. Just
yes. Yes. There's plenty of room, really.
Yeah.
Get in. Yes. Absolutely. Wow. But I also want to acknowledge that things have changed, because otherwise we can't acknowledge our successes, that the work that we've done, all the people here and further afield by trans people and allies, that things have changed, and changing rather, and otherwise it kind of takes away from what we've all done, what everyone's trying to do.
Yeah.
So things are changing. Not enough, maybe, but hopefully. With all you there, I have hope.
Yeah, thanks for organizing this, Michelle. This was great. It was a great.
Well, thank you.
Absolutely great.
Thank you for coming.
Yeah, thank you.
Thank you, Eli. Thank you, Max. Thank you, Victoria. And thank you, Sarah, for handling behind the scenes. It's great. Okay. Take care then. Should we end it there? Brilliant. Okay. Bye.
Bye.
Bye.